Imagine you have just finished running a grueling, completely brutal marathon.
Oh, yeah, like physically pushed to the absolute brink.
Right. You cross the finish line, and every single muscle in your body is screaming. You are completely depleted, and you are just desperate for a long, undisturbed sleep.
Which is what any normal person would expect after that kind of trauma.
Exactly. But instead of handing you a medal and a warm blanket, someone hands you a crying newborn baby and says, congratulations, the real race starts right now.
It's just a phenomenal physiological shift. I mean, you go from this intense physical and hormonal peak right into a state of total, absolute demand.
With zero recovery time built in.
None at all. The body doesn't even get to rest. It simply, pivots to a completely new, equally demanding biological function.
And that pivot is exactly what we are focusing on today. Welcome to the Deep Dive. We are pulling insights from some of the most intensive postpartum nursing manuals out there today.
Yeah, specifically looking at a really detailed chapter by Jennifer T. Alderman on the nursing care of the postpartum family.
Right. And the mission for our deep dive today is to demystify what the medical field actually calls the fourth trimester.
Which is such a great term for it.
It really is. It's that intense, overwhelming, and frankly, often overlooked first 3 months after childbirth. We want to explore how the medical system manages the immense physical and psychological shifts a family undergoes.
Because it's not just a physical recovery, it's a complete systemic overhaul.
Absolutely. So, okay, let's unpack this. To understand why that fourth trimester is so uniquely intense for anyone who goes through it, I think we have to start by looking at the immediate physical reality inside the hospital room right after birth.
Well, we really have to look at the timeline first. In the U.S., a typical hospital stay after an uncomplicated vaginal birth is incredibly brief.
Right, how brief are we talking?
We are talking about maybe 48 hours, and sometimes it's as short as 6 hours.
Wait, 6 hours? That's barely enough time to catch your breath.
I know, it sounds crazy. So the medical team has this extremely narrow window to ensure the mother isn't in immediate danger, while also making sure she actually knows how to keep a tiny human alive.
That is a massive time crunch.
It is, and because of that, hospitals use something called the couplet, or mother-baby model of care.
Okay, so that means instead of having, like, one nurse for the mother in your room and a totally different nurse managing the baby down the hall in a nursery,
Right.
a single nurse acts as the primary caregiver for both of them as one combined unit.
Exactly, which fundamentally changes the psychology of the care. It forces the medical system to treat the mother and child not as two isolated patients, but as a deeply interconnected system.
Because what happens to one directly impacts the other.
Precisely. If the baby is struggling to feed, the mother's stress spikes, which impedes her physical recovery. They simply cannot be separated medically.
And from what I read in the text, that intensive localized monitoring is vital because the biggest immediate threat to the mother in those first few hours is postpartum hemorrhage.
Yes. Massive, life-threatening bleeding.
The source text points out that the main culprit for this hemorrhage is something called uterine atony, where the uterine muscle essentially just fails to contract.
Right, it gets lazy or what we call boggy.
But I want to pause here because the mechanics of how the body actually stops bleeding after birth are just fascinating. It's not like a scraped knee where your blood just forms a nice little scab.
And not at all. I mean, think about it. During pregnancy, the placenta is a temporary organ attached to the inside of the uterus.
Yeah.
When the baby is born and the placenta detaches, it leaves a massive, literally plate-sized open wound inside the body.
A plate-sized wound. That is a terrifying image.
It is. And the body's only method to stop that internal bleeding is for the entire uterine muscle to clamp down incredibly hard.
So it's a muscular action, not a clotting action.
Exactly. The muscle fibers of the uterus are actually woven in a complex, crisscrossing figure-8 pattern around the blood vessels.
Oh, wow.
So when the uterus contracts, those figure-8 fibers act like living tourniquets. They cinch tight, kind of like pulling a drawstring bag, to pinch the bleeding vessels completely shut.
But if that muscle is exhausted from labor, or if it remains relaxed and boggy, those living tourniquets don't tighten, and the bleeding just continues.
Correct. And that's when things get dangerous very fast.
What I really didn't expect, though, was the role the bladder plays in all of this. The manuals emphasize that a full bladder can literally lead to massive bleeding. Wait, I'm confused by that.
It sounds weird, right?
Yeah, how does an organ that holds urine have any physical impact on an organ that just held a baby? Aren't they entirely separate systems?
Well, they are separate systems, but they share a very confined space. The pelvic cavity is surrounded by rigid bone. Things cannot expand outward, they can only expand upward.
Okay, that makes sense.
So when a mother's bladder fills with urine, it acts like a water balloon inflating directly underneath that heavy, exhausted uterine muscle.
Oh, I see where this is going.
Yeah, it physically pushes the uterus up and completely out of alignment, sometimes all the way above the umbilicus, the belly button. And because it's being stretched and displaced by the bladder, the uterus physically cannot contract efficiently.
Because it's stretched over this water balloon.
Exactly. Those figure-8 fibers we talked about, they just can't cinch down.
So a nurse isn't just monitoring the bleeding. They are actively monitoring the patient's bathroom habits to prevent a hemorrhage.
Oh, absolutely. And they can't just guess how much a patient is bleeding by glancing at a pad either.
Because visuals can be deceiving.
Incredibly inaccurate. A nurse might look at a soaked pad and guess it's, say, 50 milliliters, when it's actually 200.
That's a huge margin of error.
To manage this risk, they have to quantify blood loss objectively. They do this by physically weighing the blood-soaked items on a scale.
They weigh them.
Yeah, 1 milliliter of blood equals exactly 1 gram. It removes human error completely and turns survival into pure, hard math.
That is so intense. And if the math shows too much blood loss, the immediate treatment for a boggy uterus is a fundal massage.
Right.
The text describes it very clinically, but, reading between the lines, the nurse is literally pressing their hands deep into the patient's abdomen, aggressively rubbing and compressing the traumatized uterus from the outside to artificially force those muscle fibers to cramp and clamp down.
That's exactly what they are doing.
It sounds like an aggressive, agonizing internal workout.
It is deeply uncomfortable and often very painful. But the alternative is catastrophic, and nurses have to catch this early because traditional vital signs are actually really deceptive here.
Right, because if you are watching a medical drama on television, the first thing doctors check when someone is crashing is their blood pressure.
Always.
But the source material is adamant that blood pressure is a terrible, virtually useless metric for catching early postpartum shock. Why would the most common metric for cardiovascular health fail in this specific scenario?
What's fascinating here is that it comes down to the sheer power of the pregnant body's compensatory mechanisms.
How so?
During a normal pregnancy, a woman's blood volume increases by 40 to 50%.
That is a massive amount of extra blood.
It is. Her body has built these huge reserves. So when she starts bleeding heavily postpartum, her body recognizes the threat immediately, and it aggressively clamps down on peripheral blood vessels, the ones in her arms and legs, to keep the core blood pressure stable and protect the vital organs.
Ah, so it's prioritizing the core over the limbs.
Exactly. And it creates this temporary illusion of stability.
So the monitor says the blood pressure is fine, everything looks green, but the body is actually working in overdrive to mask a complete crisis.
Precisely. By the time that compensatory system fails and her blood pressure actually drops on the monitor, she hasn't just lost a little blood. She has likely lost 30 to 40% of her entire blood volume. If you wait for the blood pressure to drop, you are already dangerously behind. Nurses have to look for subtle shifts instead, like a slightly elevated pulse, changes in respiration, or skin that suddenly feels cool and clammy.
That masking effect is incredible. So the body is successfully hiding this massive blood loss by clamping down the blood vessels. But what happens when the mother tries to physically stand up and walk to the bathroom for the first time?
Yeah.
The body can't maintain that illusion of stability because of the pressure change, right?
Exactly. And that leads us directly to a phenomenon called splanchnic engorgement.
Splanchnic engorgement sounds serious.
It is. For 9 months, the growing baby, the amniotic fluid, the placenta, they have all been creating immense intra-abdominal pressure. It essentially acts like a compression suit, keeping blood pushed up into the upper body.
Okay, so a lot of internal pressure.
But when the baby is born, that internal pressure disappears almost instantly.
It's a physics problem. The vacuum seal is broken.
Exactly. Without that pressure, the blood vessels supplying the intestines, the splanchnic vessels, they dilate significantly.
Because there's nothing pushing against them anymore.
Right. So when the mother stands up, gravity takes over. The blood rapidly pools in her newly spacious abdominal cavity.
Oh, man.
Her brain is momentarily deprived of oxygen, and she experiences extreme dizziness, what we call orthostatic hypotension. She will simply pass out.
Which is terrifying if you're holding a baby.
Absolutely. That's why a nurse must physically support her the first few times she gets out of bed.
If you've ever wondered why your friend who just gave birth hasn't texted you back in 3 days, this is why.
Yeah, she's a bit busy.
She's not just tired. She's navigating a complex physiological crash. You have traumatized uterus, blood volume shifting violently, and on top of that, you have perineal lacerations or abdominal surgical incisions.
The body is in serious, localized pain.
But trying to manage that pain introduces a massive clinical dilemma, because whatever goes into the mother's bloodstream can end up in the breast milk.
Right, and it becomes a delicate pharmacological balancing act. The American College of Obstetricians and Gynecologists recommends a stepwise multimodal approach to pain.
Meaning they don't just jump to the heavy stuff.
Exactly. You do not start with the heavy narcotics. Step 1 relies on NSAIDs like ibuprofen. Step 2 might introduce mild opioids if the pain breaks through. And step 3 is strong opioids, but used only as an absolute last resort.
And looking at the nursing manuals, there is a massive systemic push away from opioids in the postpartum setting.
Yeah.
And to be clear, it's not just a reaction to the general opioid epidemic.
No, the medical caution here is highly specific to the postpartum physiology. There are two major reasons for it.
Okay, what's the first one?
First, opioids transfer through breast milk. If the mother takes a strong opioid, it passes to the infant, who completely lacks the mature liver enzymes to process it.
So the baby gets a dose they can't handle.
Right. This can cause dangerous sedation and respiratory depression in the newborn. The infant might simply stop breathing in their sleep.
That is the ultimate nightmare scenario.
It is. But the second reason is strictly about the mother's physical recovery. Opioids significantly decrease intestinal motility.
Meaning they slow down the gut.
They bring the digestive tract to a grinding halt, causing severe constipation.
Here's where it gets really interesting and honestly kind of horrifying. Let's think about the reality of that for a second, because this is where the medical catch-22 becomes incredibly cruel.
Cruel is the right word for it.
You have a woman who might have suffered a 3rd or 4th degree perineal tear during delivery. That means she has literal surgical stitches running from her vagina all the way through her anal sphincter.
Extremely sensitive, painful tissue.
Right. And the heavy-duty opioid meant to relieve her suffering will actually cause severe constipation, which means her first bowel movement could quite literally stretch or tear those stitches apart, causing localized agony that is far worse than the original pain.
It is a vicious cycle. You take the drug to stop the pain, and it creates a physiological condition that guarantees a different, potentially worse kind of pain, while simultaneously putting your infant at risk.
It's just an impossible situation.
That is exactly why ibuprofen is the undisputed champion of the postpartum ward.
But why ibuprofen specifically? I mean, why not acetaminophen or something else?
Well, ibuprofen is highly effective at reducing the specific type of uterine cramping pain mothers experience, but more importantly, it has a very low drug concentration ratio in the breast milk.
So it doesn't cross over easily.
Exactly. The molecular binding means very little of it actually makes it to the baby. Plus, it has a short half-life, meaning it clears out of the mother's system very quickly.
Okay, but even with ibuprofen, the nurses are essentially playing 4D chess with the timing of these medications, right?
They have to. It requires sharp critical thinking and a really deep understanding of pharmacokinetics.
Because they have to time it around the baby's feeding schedule.
Yes. If a mother desperately needs a stronger painkiller, the nurse will strategically administer it immediately after a feeding or pumping session.
To buy as much time as possible.
Exactly. The goal is for the drug to hit its peak plasma concentration in the mother's bloodstream while the baby is sleeping.
Oh, smart.
By the time the baby wakes up 2 or 3 hours later to eat again, the drug has passed its half-life and is actively clearing the mother's system, which minimizes the risk to the infant.
That is just incredible coordination. So you're constantly managing hemorrhage risks, fluid shifts, and medication half-lives.
It's nonstop.
But all of this intense physical trauma feeds directly into the mother's psychological vulnerability. The texts highlight that profound fatigue is the #1 complaint in the first 2 months.
And we aren't just talking about feeling a bit sleepy.
Right, that fatigue actively increases the risk of postpartum depression, or PPD.
Yeah.
Because the disruption to the sleep architecture is nearly constant.
Sleep deprivation is a heavily documented psychological stressor, and it's vital to point out something the literature explicitly notes here. Partners can also develop PPD.
Really, the non-birthing partners.
Yes. The exhaustion, the hormonal shifts that happen even in non-birthing partners, and just the entire upheaval of their previous life hits the whole support system.
The entire family unit is just under immense stress. But how that family unit responds to the stress and how they define recovery is heavily dictated by culture.
Absolutely.
The cultural variations in postpartum care detailed in the nursing chapters are fascinating, especially when they collide with the medical protocols we just discussed. For instance, in many Asian cultures, there is a practice called doing the month.
Right, and the underlying philosophy of doing the month is rooted in the balance of yin and yang, specifically hot and cold.
Okay, how does that apply to birth?
Pregnancy is viewed as a hot state because of the extra blood and energy. The act of giving birth, and specifically the massive loss of blood and fluid, is believed to severely deplete the mother's body of heat.
So it throws her into a cold state.
A dangerous cold state, yes.
So to restore that balance, the mother is confined to a warm room. She avoids cold drafts entirely. She only eats hot foods, like seaweed soup, which is thought to increase milk production and help heal the tissue.
Yeah, the seaweed soup is very common.
And crucially, to prevent any further heat from escaping through her pores, traditional practice dictates she must avoid showering or bathing for up to 30 days.
30 days. And we see very similar restrictive practices in Hispanic and Latino cultures with the concept of la cuarentena.
Right, the quarantine.
Exactly.
Yeah.
This dictates 40 days of strict rest. The belief is that the woman's body is open and highly vulnerable.
So they close it up.
Yes. They bind the abdomen with a cloth called a faja to provide support. They strictly avoid cool air and maintain rigorous bed rest to help close the body back up and protect the uterus.
So what does this all mean for the medical team? I mean, I see a massive collision here between modern Western medical advice and these traditional cultural practices.
It's a huge point of friction.
Just a few minutes ago, we noted that modern nurses actively push mothers to get out of bed and walk around almost immediately to prevent blood clots in the legs.
Yeah, early ambulation is standard care.
But traditional culture is saying, stay in bed for 40 days, do not move, and whatever you do, don't take a shower. How does a nurse actually navigate that in the room?
If we connect this to the bigger picture, it requires deep psychological tact and a process called cultural negotiation.
Cultural negotiation, I like that term.
A healthcare provider cannot just walk into a room with a rigid Western checklist and demand compliance. That breaks trust. But they also can't ignore the risk of a blood clot or an infection.
Right, they have medical duty.
So they negotiate. If a mother refuses to shower because she feels the cold water will damage her recovery, the nurse doesn't force her. Instead, the nurse might suggest a sponge bath with very warm water while keeping the ambient room temperature high.
It's about finding the underlying concern, like the fear of cold, and mitigating it, rather than just dismissing the belief entirely.
Precisely. If the family insists on bed rest for la cuarentena, the nurse might compromise by teaching the mother how to do active ankle pumps and leg exercises while lying down.
Oh, that's clever.
Or having her wear compression socks to prevent clots, allowing her to honor her cultural need for rest while still satisfying the medical requirement for circulation.
So the nurse is acting as a diplomat between the medical charts and the family's heritage.
Exactly.
And they have to be equally careful with traditional remedies too, right? The texts mention that if a family is bringing in specific herbal teas to help with recovery, the nurse needs to identify the ingredients.
Not to judge them, but for safety.
Right, to ensure those specific herbs don't negatively interact with the ibuprofen or the blood pressure medications the mother has prescribed.
It's all about creating a care plan that keeps the patient medically safe without alienating them psychologically.
Which is incredibly intensive care. But that leads us to what feels like the ultimate system failure. What happens when the mother actually leaves the hospital?
Ah, yes. The discharge.
Because, given this incredible complex web we've just spent time analyzing, the invisible hemorrhages, the medication catch-22s, the psychological fatigue, the traditional way the healthcare system has handled aftercare seems dangerously negligent.
Historically, the standard practice in the U.S. was to discharge the mother after 2 days and basically say, we will see you in 6 weeks for your postpartum checkup.
6 weeks. It's the equivalent of a hospital performing a triple bypass heart surgery on a patient, handing them a stethoscope as they walk out the door and saying, figure out the rest at home, see you in a month and a half.
That is a very accurate and terrifying comparison.
We would consider that gross malpractice in cardiology, yet it was the standard operating procedure for maternity care for decades.
And thankfully, the medical field recognizes how inadequate that old model is. The text points out a major paradigm shift happening right now.
What's changing?
The American College of Obstetricians and Gynecologists now demands that a mother has her initial contact with her obstetric provider within the first 3 weeks, followed by a comprehensive ongoing evaluation up to 12 weeks.
So they are finally treating the fourth trimester as an ongoing process, not a one-and-done visit.
Exactly.
But I want to challenge how effective this new paradigm actually is, because the statistics in the material are still pretty grim.
They are.
Up to 40% of new mothers skip their postpartum visit entirely. Almost half of them just don't go.
It's a huge drop-off.
The literature points out they lack insurance or transportation, or they hold the false belief that maternity care simply ends the moment the baby is born.
Or, honestly, they're simply too exhausted.
Yeah, just too tired to move.
Think about the logistics. Packing up a fragile newborn, driving to a clinic, and sitting in a waiting room just to be asked if they are healing properly is a mountain many mothers simply cannot climb.
But isn't that a massive flaw in the system itself? I mean, we are looking at that 40% statistic and essentially blaming the mothers for falling through the cracks.
Right.
If we know the patient population is experiencing systemic sleep deprivation, mobility issues, and psychological vulnerability, the burden shouldn't be on the most exhausted person in the room to adapt to the clinic schedule.
It's a highly valid critique. And to the medical system's credit, there is a growing recognition that the infrastructure itself has to change.
How so?
The text outlines several ways healthcare is trying to bring the care to the patient instead. One of the most effective strategies is the deployment of warm lines.
Okay, we all know what a hotline is, like a crisis line for an immediate 911 emergency. A warm line is completely different, right?
A warm line is a consultation service specifically for the heavy, stressful, but non-life-threatening realities of the fourth trimester.
Like what kind of things?
If a baby has been crying for 3 hours straight, or a mother is struggling with a breastfeeding latch, or even if a toddler is acting aggressively toward the new baby.
None of those are medical emergencies.
No, they aren't, but to an exhausted, hormonally shifting parent, they feel like absolute crises.
Oh, for sure.
The warm line connects them with experienced nurses or volunteers who can talk them through the issue, providing expert triage without requiring a physical clinic visit.
That is so helpful. And the manuals also highlight a push for actual home visits, where a public health nurse comes to your house.
Yes, the old school house call is coming back.
They weigh the baby, sure, but more importantly, they can pull the mother aside in her own living room and ask the sensitive questions, like, how heavy is your bleeding? Are you experiencing pain? Do you feel safe with your partner?
It completely bypasses the transportation barrier.
Exactly.
And this raises an important question about how we screen for maternal mental health. Because beyond home visits, there is a truly brilliant systemic workaround happening right now regarding postpartum depression screening.
Oh, I loved reading about
Yeah.
this part.
Since the data proves that mothers will skip their own medical appointments, the system is leveraging the one appointment they absolutely will not skip.
The baby's checkup.
Exactly. The pediatric well-child visits. The American Academy of Pediatrics now strongly recommends that pediatricians formally screen the mothers for PPD during the baby's 1-month, 2-month, and 4-month checkups.
That is just brilliant.
The medical infrastructure finally recognized that a mother will always prioritize her infant's health over her own. So the pediatrician assesses her mental health while she's already sitting in the exam room holding the baby.
It is such a smart, pragmatic solution that acknowledges human behavior rather than fighting against it.
It meets them where they are.
And I think that really brings home the core message of this entire deep dive. Whether you are a parent, whether you plan to be one someday, or whether you just interact with families in your community or workplace,
Sure.
understanding this invisible labor is crucial.
It changes your perspective completely.
It does. Seeing this sheer biological math and the intense medical reality of the fourth trimester makes you a vastly more empathetic and supportive presence.
Because you know what they're actually going through.
Right. If you have a coworker coming back from parental leave or a sister who just gave birth, you now know they aren't just tired, they are actively regenerating.
Birth is not a conclusion. It is the beginning of a profound transformation, requiring massive physical reconstruction and psychological adjustment.
And as we wrap up today, I want to leave you with one final, deeply provocative biological reality from the source text to just, chew on.
It's a wild one.
It is. We've spent this whole time discussing how broken down and exhausted the postpartum body is, how much energy it takes just to stand up without fainting.
Yeah, just pure survival mode.
But the medical manuals note that despite all of this, ovulation can occur as soon as 1 month after birth.
1 month. It's astounding.
Furthermore, some women actually experience sexual stimulation, even orgasms, while breastfeeding.
Which often catches people completely off guard, making them feel ashamed or confused. But it is a heavily documented, purely physiological response tied to oxytocin release.
Right, the letdown hormone.
Yeah.
Imagine your own body in that state. You are actively healing from an internal wound the size of a dinner plate. You are severely sleep deprived. You are producing literal, life-sustaining fuel from your own caloric reserves.
Every resource is tapped.
And yet, the human body is capable of kick-starting its reproductive cycle astonishingly fast.
It doesn't waste any time.
How does this hyper-efficient, ancient evolutionary drive to reproduce again so quickly reconcile with our modern psychological need for an extended, restful recovery?
It's a profound, almost jarring conflict between our underlying biology and our conscious minds.
The human body is engineered for survival and continuation. Its biological imperatives do not care about your emotional need for a nap.
They really don't. Biology always wins.
It does. So the next time you see a new parent, remember what is happening beneath the surface. They didn't just cross the finish line of a marathon. The real race has only just begun.